If you're stuck in gridlock traffic on the freeway due to an accident blocking all the lanes, don't you sometimes wish the center barrier would just shift even just a little bit, adding lanes from the less traffic side of the freeway? Would be nice, right? It would still allow for plenty of flow, right? For the cars traveling north, while cars traveling south now actually have a way around that blockage. Well, that's PQ bypass in a nutshell. They apply this theory to the human superhighway, our arteries and our veins. Heather Simonson is the president of PQ Bypass, and she's here to tell us more about this technology. Hi, Heather. Thanks for joining us.
Hi, Kim. Thanks for having me.
So your company is trying to create pretty much a new gold standard in care for the Achilles heel of, I think, all vascular specialists. Long calcified blockages stemming from the SFA, the superficial femoral artery in the thigh, through the popliteal artery, which is in the knee. Would you translate my highway system analogy into the reality of the PQ bypass detour system?
Absolutely. So, as you know, the unobstructed blood flow is necessary through your thigh as we move away from the heart. It's through your thigh to bring oxygen and blood down to your lower limb, so the lower part of your leg and your foot. With a certain type of peripheral arterial disease, some patients end up with these very, very long blockages of the superficial femoral artery, which is the big artery that runs down your thigh. And the blockage can be from your groin area all the way down to the knee. And what that means is that the blood hits a roadblock, if you will, a traffic jam, and really has a hard time getting down to the lower leg, to the foot, and to the toes, where it really is so necessary. And as we know, when there's no oxygen down there, that can lead to things like amputation and problems. Patients with this type of disease typically have very severe claudication. So it hurts when they walk. They really have a hard time even walking out to the car without pain. So really the quality of life is significantly impacted because there's no oxygen that's flowing. There's no blood. So historically, and the guidelines really direct that if you see a patient like this, they should have open femoral popliteal bypass surgery, or what we call fem-pop bypass surgery, which is an open surgical procedure. It's done on an inpatient basis. Patients usually spend anywhere from 3 to 7 days in the hospital, and then they either go home or go to rehabilitation, but it takes a while because there's varying degrees of incisions in the leg.
Right, there's still no consistency in incisions. We have some of our friends with peripheral artery disease that have had bypasses with still literally groin to mid-calf incisions. And then you have others that may have a 3-inch incision near the groin and a 3-inch incision down below the popliteal.
Absolutely, absolutely. And so there are the open surgical bypasses will last. Typically, they'll stay open for several years, but they're not without the invasiveness. And there are things like wound infections or nerve issues from you're cutting through quite a bit of tissue, and just the sheer recovery, right? You can't drive your car for a couple of weeks after the surgery if it's on your right side, because you have to be able to put on the brakes and move your leg. So PQ bypass, the procedure was invented by a interventional cardiologist who is really a world expert in treating in the minimally invasive treatment of PAD. And so he said, I wonder if there's another option for these patients that we can provide that's minimally invasive. And that's really where the PQ bypass procedure, or what we call the detour procedure, came to be. So kind of same thing. you hit the roadblock, and what we do is we detour around that roadblock. So the roadblock gets hit in the artery, and then we cross into the vein, travel down the vein, and go back into the artery after the blockage. And we create a bypass with kind of a tube of covered stents that start in the artery, go through the vein, back into the artery. And so the blood, the oxygenated blood, flows around that big long blockage in the leg. So it's the result is somewhat similar to an open surgical fem-pop bypass. The difference is these procedures are minimally invasive. So they're done on an outpatient basis. Patients typically go home the same day. And the recovery is essentially the same as if you were to have a stent put in.
And you typically, I mean, especially with these, you don't have the risk of the graft infections as we get in so many bypass procedures.
Right. There are things that are inherent in any open surgery.
Right. And I read the results of a study published in the Society of Vascular Surgery that PQ Bypass had done in partnership with doctors that had many patients with CTOs, or chronic total occlusions, 100% blockages, but they also had some pretty serious long calcified narrowings. What was the baseline in the clinical protocol for choosing patients, and why?
So the patients typically, or what we call, there's a scale called the Rutherford scale, and the scale goes from really 1 to 6, or maybe 0 to 6. 0 would be you have no pain when you're walking, and 6 would be gangrene or very, very serious wound in the lower limbs. So our patients were Rutherford 3 to 5. So that's typically what we call claudicants. So these are, claudication means kind of pain upon walking. So they're people who have pain while walking. It's usually pretty severe, or maybe some slight wound in their feet. So, minor ulcerations in their feet or toes, or lower limb. And then, so that was the baseline from a patient standpoint. And then ABI, I'm sure a lot of your viewers might be familiar with their ABI. So typically we looked at ABI as well. And then the lesion. So this was interesting. The lesions that the doctors could include in this study had to be at least 10 centimeters. So 10 centimeters or longer. And then they could have anything, any kind of blockage, if you will. So whether it was a CTO, which is 100% blockage, chronic, it's kind of that artery is blocked and it's been blocked a long time, or severe calcification, which is super difficult to get through, even with minimally invasive devices, or a stent that had already been there. So oftentimes people will get stents in their legs, but this disease keeps coming back. And so they get a restenosis and they have to have another procedure. And eventually they'll usually take that patient to open fem-pop bypass because the artery won't stay open. So any of those lesion characteristics were included in the study. Now, what the physicians enrolled, the patients that they treated, the average lesion length was about 35 centimeters.
Wow.
And so our shortest lesion treated in that particular study was 20 centimeters. So I think there were 2 of about 80 that were less than 25 centimeters, and all the other ones were extremely long.
It's interesting. I bet you had the same situation as I've seen in multiple device studies for peripheral artery disease, where the doctor says, well, I get approached all the time from all of these medical device companies that say they have the biggest breakthrough. Well, if you have the biggest breakthrough, I'm bringing in my toughest of toughest patients, and let's see if it really works.
Absolutely. And we had a pretty open window for them, it was a pretty generous inclusion criteria from a lesion standpoint. That, starting at 10 and going up from there, 96% of those lesions that were treated were CTOs. And so the average CTO length in that study was 15 centimeters. So you can imagine 35 centimeter long lesion, 15% of that is 100% occluded. And the rest of it either has severe calcification or it's highly diseased. So these are really, really, they're extraordinarily complex lesions, and they're really not well suited for your typical stent.
No, I mean, who wants to sit there with an atherectomy device for hours and just go step by centimeter by centimeter by centimeter? Like, who has the time? I mean, the longest procedure I was just in recently was literally 8 hours because there was a 13 centimeter long calcified CTO. And, it was just enough where they could just barely just get through this calcium, but it took forever. The patient had refused an invasive procedure and they needed to do it to save the leg. But if they had the PQ bypass detour system, I'm sure that would have been a preferable option. It would have been much faster. How, is this a typical standard time for a minimally invasive procedure, or does it require extra time beyond what you would think for an angioplasty plus atherectomy?
So if you're looking at the time for that type of situation that you just described, that type of lesion, they're using atherectomy, they're using different wires, they might be using a crossing device, they might have to try to go up from the foot if they can't cross the lesion. This is much shorter time. So this is much shorter, a little bit more in line with the typical atherectomy plus stent procedure.
They can still get between 4 to 6 patients in a day for just a standard day.
Yeah, absolutely.
Well, I also looked at the results of that study in the Society of Vascular Surgery publication, and showed most of the patients had significant improvement after a month, and then even after a year as well. What's the longest patient that you've tracked thus far, and how are they doing today?
We have patients, we haven't published this data yet, but we have patients out to 5 years from that study.
Wow.
So we've got patients out to 5 years. And in fact, I just spoke with the investigator, and there's one center in particular that I want to say he maybe treated about 10 or 11 patients. And he said, listen, they're doing great. They're doing great. So they will be, the investigators will be publishing that data. So the paper that you saw was the 1 year results, and then the 2 year results will be coming out very shortly. So that was just accepted for publication.
We want to go 5 years. That's going to be the real game changer there.
That will be amazing. And that's when the investigators came to us, that's, most endovascular studies usually just kind of look at 12 months. And so we're looking at a very long time. And that's really that's really where the rubber meets the road, is once you see out to 5 years and what happens. But the nice thing about that study and really what we've seen is the patient experience. So at the beginning of that study, the patients were primarily Rutherford 3 and 4. So out of a 6, they were 3 and 4. A month later, 6 months later, 12 months later, the majority of those patients are Rutherford 0, essentially.
Oh my goodness.
Yeah.
That's amazing. And how, are these patients, are they tracking their walking programs? Are they walking? Are they eating right?
So are they monitoring? Yes. So absolutely. So we'll have more once when the data comes out.
Because I would think that would be an important point to make. Now, one study I read analyzing femoral popliteal bypasses showed a 37% major and minor complication rate, with complications including, I mentioned before, graft infections, postoperative bleeding, edema, What so far has been the complication rate during trials of the PQ bypass?
Sure. So we published data on our first in man study, and we are in the process right now. The follow-up window for our US pivotal study, so roughly 220 patients. And so that data is not, I'm not privy to that data, but I can talk about the data that we've published. The complication rates. So you don't see things like you would see with an open surgery. So things like wound complications, typically you don't see. So our safety rate was, I think we had roughly, it was like a 2%, very low 2% complications within 30 days. And that includes just, I think one reintervention. So it's actually been it's been in line with what you would expect from a stent procedure, from a minimally invasive stent procedure. That's probably a good way to say it. And we're very happy about that because as mentioned, when you look at kind of the two different options, well, it appears that it has a better safety, that this has a better safety profile than an open surgical procedure. And it appears to be really in line with a typical endovascular procedure. However, our lesions are really surgical lesions. I mean, it's a real complex disease. So, and that really was the vision of this procedure, of the technology, was can we provide a good alternative for the most complex lesions and do it on a minimally invasive basis?
You would imagine with our bodies that they're designed in a certain way for a reason, and the veins are the size they are for a reason. Is there any downside that doctors have expressed or concerns they have expressed to taking up half a vein in these patients?
Well, I think that your point is actually the statement you made of half a vein. That's really the key point. So we borrow some of the real estate within the vein, anywhere from 50-60%, which means that you've got through the bypass, so through the stent graft, you've got arterial blood flowing away from the heart. And then you've got venous flow on the outside of it. So going back to the heart. And because we aren't occupying that full vein, the body accommodates. And so the body accommodates the, kind of the partial occupation, if you will, and the lumen, or the area within the vein is still preserved enough to not disrupt what needs to occur in terms of the return flow. And we just published in the Journal of Vascular Surgery, they have a special publication on the venous and lymphatic system. So we actually just published our 12-month results answering the question, what happens to the vein after this procedure?
Yes.
So what is the disposition of the vein at 30 days, at 12 months? So that was just published in January of 2021.
And
yes, and yes. So and the results are they're great. They're great. What we saw was 100% venous patency at 12 months. We saw the luminal preservation. So sometimes the vein actually expanded a bit to accommodate the bypass. There was no incidence of any kind of real disruption to the venous flow. So we looked at, there are a couple of measurements, Villalta, kind of a scale that the doctor rates on the patient on several things. Is there edema? Is there, et cetera, et cetera. And so we saw that was basically same from baseline to 12 months.
Have you been in a case to watch the PQ Bypass Detour System being used?
Several cases, yes.
Was there any sort of aha moment where you were like, oh my gosh?
You know, my favorite, probably one of my very favorite parts of watching the procedures was our first case in the US, which was in Arkansas. And the investigator, he finished, he turned, he looked at us and he said, that was much easier than I thought it would be. Because what they're doing when they do this procedure is very, what would I say? It's the same skills that they are using every day, whether they're doing atherectomy or stenting and guide wires. So we're working with guide wires, we're working with stents. They're our own, they're specialized for this procedure, but we're not teaching a brand new, we're just using them in a different way. That's probably a good way to say it. So once the investigators perform a couple of cases, then they're off to the races. And I think the best part for me is really the impact that we are hoping this has on patient quality of life.
Is there anything in that study that you learned along the way that caused you to modify either training or device features or process?
Mm-hmm.
Because there's always a lot of learning during those studies, and things
Right.
evolve as you go along as different operators use it in different ways.
Yes. Well, I can say when what's really advanced with this, with what we've been doing is really our training and the training process, because at the beginning we were still learning as well alongside our investigators. And so the more we had, I don't know, in our first study, let's say we had maybe 12, 14 centers that were performing the procedure. And then we went to 40. Wow. Across the US and in Europe. And so then 40 plus you have a few investigators at each site. All of a sudden you have a lot more physicians that are using your technology and performing the procedure. And what's been fantastic is they learned, we learned, and we kind of adjusted along the way. I would say the very first procedures took a very long time. Very long time in terms of planning and actually kind of figuring out the different steps. Whereas today it's pretty, what would I say? It's a very, very, we've really kind of figured out the recipe, if you will, for training and for kind of teaching the physicians. And so they really, within a couple of cases, they're good to go.
Wow. That's a lot of sites.
Yes, absolutely. Absolutely. Well, it was important. I mean, when you're looking at a brand new procedure, right? This has never been done. Mm-hmm. And that's what's really exciting about this. This has never been done. And we are collecting the data to show that it is safe and effective. And with that, you don't want just the top 5 experts in the world doing it. You want everybody, really everybody who is skilled to do so.
I hate to say it in this way. You want even the ones with the minimal skills to be able to accomplish successfully. Exactly.
Yes.
And so where are you at in terms of bringing this to full FDA clearance?
We are about, I would say, about a year, 15 to 18 months from expected FDA approval. So we are, as I mentioned, we are following up on our Detour 2 was our big pivotal IDE study. And we are following those patients to a year. So many of them have already come back for their year follow-up, and we've got maybe 25% more who still have to return for their year follow-up. And then we submit the data to the FDA and they have their review process. And so we're expecting roughly about 15 to 18 months from today. We've also just started what's called a continued access program. So where we, this procedure, it's something the FDA makes available during this process of review and approval to allow patients to still have access to this procedure. So we have a continued access program that is just getting underway. So there will be centers in the United States, hospitals and outpatient facilities where patients can go for this procedure if they meet the inclusion criteria.
Oh, that's incredible. I like that you're including multiple types of facilities, both office-based labs as well as hospitals, as well as universities.
Oh, yeah. Oh, yeah. We haven't, in fact, in our pivotal study, there were no patients in the US. Everybody was treated either in a hospital outpatient setting or in an office-based lab. So there were no inpatient procedures.
That's even more encouraging. And you had a variety of interventional cardiologists, interventional radiologists, and vascular surgeons who...
Yes, multi-specialty.
So what sort of resistance do you expect to face from in the market, you know, as you execute your go-to-market strategy?
It's interesting because when I started in this field 25 years ago, 20 years ago, surgeons pretty much did open procedures. And the interventionists, whether interventional radiology or interventional cardiology, they did the minimally invasive procedures. Today, surgeons that are coming out of fellowship, they are learning both open and endovascular procedures because that's really changing in terms of patient demand. And also, so we have, this procedure has, I would say, if we look at our investigators, I would say 65, 70% of our investigators are vascular surgeons. And then the rest would be interventional cardiologists or interventional radiologists. What's important for us is just that the operator has an active interventional practice. So they know how to use the wires and. So
a patient may say, "Hey doc, you're telling me that I need to have an invasive bypass procedure. How would that patient know if maybe a PQ bypass might be an option?" So that'll be really interesting to know when a doctor would decide, you know, a doctor who could potentially do an invasive bypass has the ability to do a PQ bypass or has the ability and the skill set to do angioplasty and atherectomy and even stent if they need to, when they would make the choice to choose PQ bypass or not.
Mm-hmm.
Has anyone talked about that yet?
Not yet. We're a little bit early. Where that has come up a little bit in discussion is, does it preclude a future bypass, right? If for some reason, and so no, they can, if for some reason in the future, the patient still had disease, or maybe for some reason it progressed, it does not preclude a future bypass. And so that's really one of the big things that physicians look for. They like to keep future options open. Mm-hmm. So, yeah.
Well, thank you so much. We wish you the best. We appreciate your time. Heather Simonson, president of PQ Bypass, and we've been talking about their PQ Bypass Detour System, which is about 15 to 18 months out from possible FDA clearance, but there is a continued access program that we will be keeping an eye on in the meantime. Thank you so much, Heather.
Thanks, Kim.